Yeah, thank you, and welcome to, I think it's Jessica Ying. You must correct me if I'm wrong. I have really looked forward to this talk, and Jessica is an associate professor of medicine in the General Internal Medicine Division and a co-faculty member of the Welk Center for Prevention, Epidemiology, and Clinical Research at the Johns Hopkins University. And Jessica is a very experienced researcher. And lastly, she has been a senior archer at the clinical at a review with the name of Clinical Intervention to Break the Obesity and Cancer Link. And I think that's very in the core of this seminars or webinars. So now I'm very excited to hear what Jessica has wanted to tell us for today.
Okay, thank you so much. Good afternoon or good morning, depending on where you are. Thank you for having me here. So today we are going to talk about epidemiology, and the connection between diabetes and cancer is such a big topic. So I'm going to talk about some recent studies and talk about some study we are doing locally in Maryland. Okay, let me get started. Diabetes and cancer are both common diseases and share several risk factors. And most of our understanding of diabetes and cancer connection actually comes from observational studies. While there are many consistencies, several methodological issues should be considered when making inferences. Data from clinical trial of diabetes prevention and control on cancer incidence and cancer progressions started to be available, but are still limited. So a little bit about my journey, because I think there are students among the audience. So I did my undergraduate in public health at National Taiwan University. And several years later, actually many years later, I got my PhD in epidemiology at Johns Hopkins University School of Public Health. And my PhD thesis was around radiation exposure and cancer outcomes. And after that, I was recruited to School of Medicine to work on diabetes project. And later on, I had started to have an opportunity to work on the space between obesity, diabetes, and cancers, and starting with a systematic review and meta-analysis, and then did some analysis in cohort studies, and currently, or more recently, doing clinical trial of lifestyle interventions. And I'm also working on other diabetes projects. Okay, so 3 topics today: diabetes and cancer incidence, weight loss and cancer, and metformin and cancer. So the goal of this presentation is to, the goals are to review the association between diabetes and cancer incidence and mortality, summarize the effect of weight loss on cancer, cancer incidence in observational studies and clinical trials, and update the association between metformin and cancer risk and cancer survival, and identify the methodological challenge in assessing associations. Okay. All right, so let's start with some basic epidemiology prevalence data. So adults with diabetes have a higher prevalence of cancer compared to those without diabetes. So when we use the data from the NHANES National Health and Nutrition Examination Surveys, which is a nationally representative sample in the US. So when we use the NHANES data to look at diabetes, cancer prevalence in diabetes populations, and we found the age standardized prevalence of cancer in adults with diabetes was about 11.5% compared to 9% in those without diabetes. So it was higher in the people with diabetes in terms of cancer prevalence. And as I mentioned earlier, diabetes and cancer share many risk factors. So some of those risk factors are non-modifiable, and some are modifiable. So non-modifiable factors include age, race, sex, and modifiable factors include like obesity, smoking, diet, physical activity, and alcohol consumptions. And the common pathway between cancer and diabetes, the current hypothesis is through hyperinsulinemia and or hyperglycemia. So here are data from a newer study based on Swedish registry data. They look at the cancer incidence in type 2 diabetes compared with background populations. So what they found here is diabetes is associated with incidence of all those cancers listed here pretty strongly, always has a ratio of relative risk more than 1.2. And the top 3 cancer most strongly associated with diabetes were liver, pancreas, and uterus. So this is a recent published meta-analysis study, shows results. There were combining data from 150 cohort with 32 million people. And what they found here, the study results are pretty consistent with the Swedish study we just saw. So diabetes is associated with many type of cancer specifically, and with the strongest association, again, with liver, pancreas, endometrium, and gallbladders. And all those relative risk were more than 1.5, suggesting more likely to be a causal relationship with such strong association. Okay. So this is prospective study using data from Harvard's Nurses Health Study and Health Professional Studies. And it's they assess the diabetes duration and risk of cancers. So as we can see here, so the x-axis is duration of type 2 diabetes, and the y-axis is hazard ratios. And what they show here is the cancer risk actually peak at 6 to 8 years after the diagnosis of diabetes. And the risk actually decrease after year 8, after 8 years after diabetes diagnosis. And the study also presented the data showing similar duration-dependent association in plasma C-peptides. So what they found here is the C-peptide level actually peaked around 4 to 8 years after diabetes diagnosis. And on the other hand, the HbA1c data, the HbA1c value increased over the years. So the study investigator kind of suggesting the underlying mechanism is more related to hyperinsulinemia, because the C-peptide pattern is more consistent with the analysis with cancer incidence. Okay, so in this, so a couple years ago, my trainee actually looked at HbA1c and mortalities in older adults with diagnosed diabetes using enhanced data. And what we found here is the HbA1c level in people with diabetes actually associated with cancer mortality if when the HbA1c level is more than 8%. So like the hazard ratio is 4.7 with cancer mortalities when the A1C is more than 8. So compared to that, in the same study, we also look at the all-cause mortality. So it suggests A1C 8% as like a significantly higher risk in terms of all-cause mortality, and CVD mortality is about 2.5, hazard ratio 2.5 when A1C was higher than 9%. But the cancer incidence data was not available in enhanced studies. And cancer mortality data, a lot of time is a good indicator for cancer risk, but it's not always the same because the cancer mortality include both cancer risk and cancer survival or cancer progression, right? So cancer progression, it's more complicated. It can be related to cancer treatment or other comorbid conditions. And in some studies, we found the association between diabetes and cancer mortality is actually stronger than diabetes with cancer incidence. So it may suggesting some diabetes play a role, an important role after the cancer diagnosis. So if diabetes is associated with increased risk of cancer, so the question is whether diabetes prevention or control can reduce the risk of cancers. So one of the diabetes prevention strategy is weight loss. Previous literature already show excess weight is linked to increased cancer risk, but evidence is limited on whether the excess cancer risk can be reversed through intentional weight loss. This is result from pooling project of prospective study of diet and cancer. And this project actually combined data from 10 prospective studies. And this study found after 10 years, compared to people with stable weight, the stable weight group, those who had stable weight loss had significant risk reduction for breast cancer among women aged 50s or older, not taking postmenopausal hormone therapy. So compared to the weight stable group, even those who lost as little as 2 to 4.5 kilograms of weight, they have about 20% of risk reduction for breast cancer. How about bariatric surgery that produce additional weight loss, a lot of weight loss? So results from bariatric surgery study generally show reduced risk. And this earlier meta-analysis show the benefit from bariatric surgery on cancer incidence is more apparent in women, not in men. Yeah, so, but remember, bariatric surgery produce a lot of weight loss, but none of those studies are clinical trials. And there's still issue with residual confounders. As I mentioned before, so limited data available from long-term clinical trial to evaluate the effect of intensive lifestyle intervention for weight loss on the risk of incidence in the incidence cancer or cancer mortality. And in 2020, we published a paper using data from look ahead trials, and cancer was a pre-specified outcome in the trial. So cancer cases were adjudicated throughout the studies. Look ahead trial was a multi-center randomized clinical trial originally designed to examine the long-term effect of intensive lifestyle intervention program on CVD, mobility, and mortality in overweight or obese person with type 2 diabetes. And because patients with diabetes have elevated cancer risk, for the look ahead trial provided a unique opportunity to study cancer outcome in a high risk population. The goal is to investigate whether participants randomly assigned to intensive lifestyle intervention, or ILI, had reduced cancer incidence or cancer mortality compared with control that received diabetes support and education. Look ahead trial had many, actually many inclusion and exclusion criteria, and the major criteria on age is 45 to 76, and BMI must be above 25, it has to be overweight or obese. A1C lower than 11%, and actually the participant has to be able to complete a treadmill-like exercise test. And if patient have a cancer requiring treatment in previous 5 years, except for skin cancer, were not eligible for the trial. And the trial randomized 5,145 people into 2 groups. The comparison group received diabetes support and education. It's not entirely nothing, but they actually receive a lot of education. And the intervention group is intensive lifestyle intervention focusing on weight loss. Okay, so this graph shows the weight change over 12 years. And as expected, there was a significant weight reduction in year 1 in the ILI group, followed by a weight regain. But as shown here, the intensive lifestyle intervention group reached about 9 kilograms of weight loss in year 1 and may remain lower weight on average than the comparison group. And participants in the control group actually also have some weight loss, and some of those weight loss may be related to age, old age, particularly those weight loss in the later years. So this is like one of the primary outcomes in the papers. The Kaplan-Meier curve shows cumulative incidence of obesity-related cancers. So it shows the ILI, the intensive lifestyle intervention group, had lower obesity-related cancer incidence consistently throughout the follow-up, and the separation actually started pretty early on. The hazard ratio is 0.84, the confidence interval including 1, so it's not statistically significant, but the direction was toward what we expected. We did not, in the pre-specified subgroup analysis by patients' characteristics, we did not see any significant interactions between intervention and people's characteristics. So the data from Look Ahead trial indicated an intentional lifestyle intervention aimed at weight loss, lower cancer incidence of obesity-related cancer by 16%, and in adults with overweight or obesity and type 2 diabetes. And the 95% confidence interval did include 1, but that was likely because of insufficient sample size. So Look Ahead study, although already have 5,000 people, but for cancer study, it's considered not big enough. And Look Ahead study, anyway, is the only randomized trial that examines long-term cancer outcome in an intensive lifestyle intervention setting, focusing on weight loss. Okay, there are several limitations. So the major one is Look Ahead was limited to adults with type 2 diabetes and high BMI at baseline. and whether the finding from look ahead can be generalized to all the adults with excess adiposity is not known. We still have an insufficient number of many site-specific cancers. I didn't show it here, but what we suggest is maybe in the future, we can pull data from weight loss trial with long-term follow-up. That will be useful to assess the effect of weight loss on cancer risk. And another suggestion we had is maybe future long-term trial of weight loss should include obesity-related cancer as a pre-specified endpoint for adjudications. So doing adjudication prospectively instead of going back. Another limitation from look ahead is we did not have a complete information on cancer stage at diagnosis. Okay, so in the next about maybe 10, 15 minutes, I also want to comment on metformin in cancer. So metformin being discussed quite a bit in the literature as a way for cancer prevention. So so let's look at some data from recent studies. Okay, sorry, I did something here. Did I mute everyone? Tina?
Yeah, but I think it's fine. Yeah,
okay.
I'm
all right.
Yeah, so you're good to go. No
okay,
problem.
Great. Thank you. Okay, so metformin. So in the preclinical studies, the preclinical study show metformin inhibits cell proliferations, reduce colony formation, and prevent tumor development. So the question is, does metformin reduce the risk of cancer in clinical studies, right? So many early cohort studies, if you look at literatures, many early cohort study and meta-analysis, specifically, particularly those published before 2012, pretty much all of them indicated metformin may reduce risk of cancers. But there was flaws in methodology in observational studies. So in the literature, there are a lot of discussion around confounding by indication or time-related biases. For example, the immortal time biases. In the end, like metformin was the first line treatment for diabetes. So if we compare people with metformin to adults in other different type of medication, whether they may not be comparable at baseline, only because the characteristic of their disease. After reducing or removing those biases by using better study design, for example, new user design or proper comparison group or time variant analysis, the protective effect from metformin actually attenuated to null. So like in the older literature, the design in general is metformin, yes, no, ever, never metformin compared to another group. But in a better design, it can be like a metformin initiator, new user design versus sulfonylurea initiator. So new user versus new users. Those are better design compared to just ever, never, or yes, no type of fixed time analysis. So there are a lot of papers out there talking of analyzing the association between metformin and cancer incidence based on newer and better methods. So we also published this review paper, summarize the result from low risk of bias cohort studies. And I know this slide is very small, you cannot see all the details, but I hope you can see the hazard ratio around here. It was all around 1 in those low risk of bias cohort studies. Okay, so just to summarize, we talk about some considerations in metformin studies. So first of all, most of people with diabetes were treated with one or more medication. It's difficult to assess independent association from metformin on cancer incidence. And many analyses were still have a confounding by a major or incomplete and major risk factor, especially in electronic or medical record type of studies. So those major risk factor can be behavioral risk factor, right? Like a diet or physical activity. Those are examples. And those analysis or those studies still require frequent data updates on medication. So medication changes need to be documented completely and well in medical records. And this can be a challenge if you are doing population level of cohort studies. In that setting, you cannot update medication every couple months frequently. And lastly, generalizability. Generalizability, whether the study, most of the study were done in patients with diagnosed diabetes, whether the effect from metformin can be generalizable to people without diabetes is not known. Okay, so these are data from the diabetes prevention program in the US. So they recently published their long-term mortality paper, actually last year's. And we can see here is compared to metformin compared to placebo or lifestyle compared to placebo. You can see there was no mortality benefit in either interventions. So for cancer mortality, the hazard ratio is around 1 in both metformin compared to placebo and in lifestyle intervention compared to placebos. So diabetes prevention program has not published their cancer incidence data, but it will come up sometime in the near future. But the question we should think about is whether mortality is a relevant outcome in diabetes prevention program, right? So diabetes prevention program was designed to prevent diabetes. That's more like short-term outcomes. And mortality, this is like 20 years after the intervention phase. So maybe mortality is an outcome to distance from the intervention. Okay, here is some result from MA32, and MA32 published their main result early this year, and it was a phase 3 randomized clinical trial in multiple countries, and they randomized 3,600 non-diabetic patients with high-risk breast cancer already receiving standard therapy. And the intervention period was 5 years. Their primary outcome was incidence rate for invasive disease-free survival event. As shown here, the hazard ratio is 1.01 metformin compared to placebo. But in their exploratory analysis, they did show metformin increased survival in this very specific subgroup of women with breast cancer. So we can expect more results come out from this large clinical trial of metformin. But I think a lot of result will be around the biomarkers of result. So in the last few slides, I do want to share some data from a study, a clinical trial we conducted in Maryland. And it was a randomized clinical trial of metformin and behavioral weight loss in cancer survivors with overweight or obesity. So in this trial, it's called SPIRIT. We randomized 121 people into cancer survivors with overweight or obesity into 3 groups. self-directed weight loss, which is like a comparison group, and coach-directed behavioral weight loss delivered by web or telephones, and metformin treatment. And primary outcome we chose was IGF-1, insulin growth factor 1. And IGF was measured at baseline, 3 months, 6 months, and 12 months. Okay, so this graph shows percent weight change over the study period. As expected, the self-directed comparison group lost a little bit weight, but not too much. And metformin group lost quite significant amount of weight over time from baseline to 12 months. And the coach-directed weight loss group lost a significant amount of weight, about 3.5% at 3 months and 4.2% at 6 months, and regain some weight in 12 months. So those those patterns were expected, just like other weight loss trial. So this is data from IGF change. There was no significant changes in IGF in the self-directed comparison group, and no significant change in the coach-directed behavioral weight loss group. But in the metformin group, participants in the metformin group, a significant reduction in IGF-1 at 3 months, but the level returned to almost baseline after 6 months. In subgroup analysis exploring potential differential intervention effect, we found participants in the metformin group had a significantly decreased IGF-1 at 6 months among those who had obesity at baseline. And because a significant result in metformin at 3 months, so we did additional analysis using 3 months data. And interestingly, we did find a linear dose response relationship between a metformin dose and IGF reductions. So those who receive who take metformin consistently and have a higher average metformin dose had more reduction in their IGF-1 at 3 months, but only at 3 months, the level returned to baseline afterwards. And we also look at the IGF-1 to IGF-BP3 ratio, but we did not find any associations. In SPIRIT, we also collected stool samples, and we did a microbiome analysis. I'm not going to talk about microbiome result here because it's a separate topic and pretty technicals. But it's very interesting to see like longitudinal changes in a clinical trial setting and over 12 months. I was told 12 months is considered long-term in microbiome studies. We did in this paper, we did find like metformin changed the microbiome composition, like increase the abundance of certain microbiomes, but we did not see that type of effect in weight loss food. So if you are interested in microbiome, we're happy to discuss separately. Okay, just some conclusion about the challenge of clinical trial for prevention of cancer risk of cancer development. So first of all, there is uncertainty of deciding of interim biomarkers. So traditionally, the inflammation markers, sex hormones, insulin growth factors are in the causal pathways, but their role and their effect may be different for different type of cancers. And in the SPIRIT trial, we chose IGF, but whether that was the right outcome to look at, we are not sure. Maybe not really, but we still have a pretty interesting findings. So the search for clinical relevant surrogate markers must continue. So for example, adenoma for colorectal cancer and breast density or hormonal levels for breast cancer would add considerable confidence to expensive intervention study with long-term follow-up. And regardless of surrogate markers or direct clinical outcomes, study would always require very large sample size. And we also uncertain about the effective intervention dose. So for example, how much weight loss are needed and when to lose weight and for how long, or how much metformin dose are needed and for how long in terms of medication. We are not certain about that. And regardless of intervention, substantial changes are needed for significant effect. So for instance, in the look ahead trial, the intervention group actually reached more than 9 kilograms of weight loss in year 1 and sustained 6 to 7 kilograms of weight loss over time. So that kind of change was not small at all. So I think what we learned from clinical trial is the benefit, the value of observational studies. I think a better designed observational study and better analyzed observational study are very important because that will inform the next clinical trial and compensate the disadvantage in clinical trial that we are not able to measure, and the long-term outcome we cannot see in clinical trial setting. So in summary, diabetes is associated with many increased cancer incidents, particularly pancreatic, liver, and endometrial cancers. Significant and sustained weight loss may reduce obesity-related cancers based on observational study and some clinical trial data. Metformin seems not associated with reduced risk of cancer or better survival, but may change short-term biomarkers in the pathway, which can be a target for therapeutic purpose. Okay, so that's it for my presentation. Thank you.
Thank you, Jessica, for a very interesting talk. If anyone has some questions, they can, for Jessica, you can write it in the chat, or you can raise your hand, and then we can, Jette can open for discussion. And maybe I can be the one to start, Jessica. First of all, congratulations with your Look Ahead trial. I really think it's a very huge work. A lot of people, a lot of work must have been put into that. What I was wondering is, do you have any kind of biology or a marker, or have you thought of, would it be possible to kind of predict in this high-risk group who among those are going to have obesity-related cancer? Do you understand? So could you kind of do a prediction model, or because that will be the one that you wanted to go for screening or have a
that's
at a higher risk group than, but still.
Yeah, that's a great research question, and exactly what we are trying to do. So Look Ahead study, yes, Look Ahead trial already finished. So the funding for Look Ahead is over, well, for now. And there was a lot of biomarkers, or like a lab already collected, sample collected, and several studies are analyzing different type of biomarkers. So we have a new grant measuring like a sex hormones, and there was a different study measuring like inflammation markers. So we are in the process of trying to put all those data together and cancer was not one of the high interest outcomes originally. A story was like 10 years ago. My advisor over there was a PI, one of the PI from the site, and we insist to include like cancer outcomes as a adjudication outcome, and we were successful at that time. That's how we are able to look at cancer data at this moment. Yes, but that was a great question. We definitely want to do that. And another thing is the paper I presented with our cancer data was up to like 2015. So I'm in the process of getting additional data, later data, because participants are getting older. So there are more cases. Unfortunately,
yeah,
yes,
that would,
but
yeah, that would definitely help.
Yes.
Yeah, and then there's someone in the chat, but I had that, but I can't read it.
Yes. So there is a question: why diabetes particularly associated with cancer of liver and pancreas? Yeah, good question, right? So I think it's all digestive system related cancer. So diabetes, right? It's related to pancreas specifically, and liver also related to insulin secretion. All the mechanism pretty tightly related to diabetes physiologically. That's my interpretation. But I will be happy to know what other people think about this association. Good question.
I have another one, Jessica. That was from the first. That was that the incidence of cancer peaked at 8 years, and then it down.
Mm-hmm.
I haven't heard of that, and I kind of, why is that?
Why is that? Yeah, so that's that's an observation from this large cohort, right? The nurses' health study and health professional study. That paper was published in 2020, so pretty new, large sample size. So like what they trying to see, I think that they were trying to explain the association. That's why they include this data in C-peptide, and showing like C-peptide also peak around like 4 to 8 years after diabetes diagnosis. I think physiologically, the diabetes at the early diagnosis, our body is trying to secrete more insulin to try to compensate the diabetes itself early on. And later on, maybe pancreas stop working well, so insulin level decrease, and that's why the hypothesis was hyperinsulinemia, because of that extra insulin secretion during that period of time, so promote tumor growth. I think that can be one mechanism.
Wow, yeah, that was a good expected. Yeah, that makes sense. So that's when you have a long time for the duration, and that's also where at the time point you ended up putting your patient on insulin.
Yes,
they are not able to kind of compensate any longer.
That's right. That's right. Yeah. So that's a hyperinsulinemia pathways, and it sounds reasonable, but I think people out there have a observational study available. We all can look at that in terms of association between diabetes duration and cancer risk, right? That will be a topic for someone to work on. Okay, so there is another question on the chat. Could you repeat how data on adenoma on the path to colorectal cancer could be used in future study? Okay, good question. So what I was trying to say is cancer outcome is a very long-term outcome. We have to be able to follow up a group of patients for 20 years to do the clinical significant outcome. So for colorectal cancer, adenoma is like a colon polyps. can be like an indicator for early tumor risk. So I was trying to use that as an example. It can be an earlier biomarkers compared to the clinical outcomes. And there was actually this, I remember, was a clinical trial done in Japan, paper probably published in Lancet Oncology, yeah, in 2016, around 2016. There was a clinical trial, they used metformin, and they saw a decrease in colon polyps in metformin group. Sample size was small, but I think that was interesting, and that also motivated me whether we should consider colon polyps as outcomes. But it's still hard to do. You have to, patients have to be willing to go through all the screening process frequently, more frequently than guideline recommended. But yeah, thank you for the question.
Any more questions? I think I don't have. Yeah, I can't see the questions. Is there any more questions for Jessica?
No more questions in the chat.
No, but then I think I will say thank you very much, Jessica. It was very interesting, and I think you have some very good perspective on this. And thank you for attending, and thank you everyone for listening. And we are going to have our next webinars on
Tuesday,
the 11th and 13th of October.
Okay, thank you so much for having me. You can Google me and find my contact information if you like to talk about your study or make collaborations. Yeah, thank you so much.
Yeah.
Bye.
thank you.
Bye.